Thank you for doing that with us. As David said, if you need to take a break, stretch your legs, get a drink, please do that during the session. We're here all together. But we are so honored to be here for the Dr. Lorna Breen Heroes Foundation. We were created 5 years ago when Lorna died by suicide, and her story became national news. She was an emergency room physician that sought her first ever mental health treatment after having COVID and treating COVID patients during the beginning wave in New York. Corey and Jennifer Feist, Lorna's brother-in-law and sister, started the foundation because after her passing, they heard so much from so many health workers that Lorna's fear of seeking mental health care and not being able to practice medicine was real, a real fear because of how our health system operates and the policies that are in place. Lorna was not alone. Now, nearly half of our healthcare workforce experiences burnout, intends to leave their job while we're already under this shortage. And on top of that, the CDC 2 years ago said that the health workforce has poor mental health and being harassed at higher rates than any other workforce in the country. And so we are dedicated in changing that with the partners like many of you in the room so that we can address the operational environment that's driving the burnout, while also changing how our industry supports mental health. And so we look at that through this lens of a Venn diagram, thinking about what are the comprehensive solutions that we need for our healthcare workforce. As many of you know, burnout is an occupational syndrome. And so that's why we need to look at the operational environment on how do we change the system and how do we make sure the system provides individuals with the support they may need. But it's complex and it could also drive to mental health conditions. And so if health workers have mental health conditions, we need to make sure that they don't have barriers to access confidential care, just like anyone in America. And so to dive a bit deeper into that, when we look at burnout, administrative burden is the number one driver of burnout. And for you all in the room, a component of that is the computerization of practice, thinking about EHRs and all the tasks that have to happen in charting and paperwork through the use of technology and other tools. Excuse me. On the other side, health professionals are at an increased risk of suicide. Like I mentioned with Lorna's story, this stigma associated with talking about and seeking mental health care is one of the top drivers of suicide for the health workforce, who do die at higher rates than the general public from suicide. And that is because of their inadequate access, this fear, as well as their unique job-related stressors. So with that, this amazing Commonwealth and many organizations in this room came together 3 years ago to launch Caring for Virginia's Caregivers, to really make Virginia the best place for a health worker to work. Oops. So how we did that, it was through interdisciplinary collaboration. So not just the health systems here, but all the different professional associations in the Commonwealth coming together and making a commitment to do this work. And the work that has done in Virginia has spurred similar statewide initiatives in North Carolina, Wisconsin, New Jersey, and there's many others that want to join in and do this as well, because Virginia did it first and showed how powerful and impactful it could be for our workforce and our healthcare outcomes. Over the past 3 years, we did 3 phases of work to get at all these comprehensive solutions, to help break down these barriers to help seeking, really look at the systems and integrate it into operational improvement. So what does this mean? So at first, we came to get together to look at what can we do that's high impact and low cost. And that is directly aligned with what we heard from Lorna. There's these intrusive, stigmatizing questions on licensing applications and credentialing applications, asking health workers about their past mental health diagnoses and treatments, which one doesn't align with the American Disabilities Act, but also it prevents health workers from seeking mental health care because they fear that they have to disclose if they had any type of treatment. So together as a coordinated group, 75% of the hospitals across the Commonwealth have removed these questions and made it safer for health workers to seek mental health care. On top of that, we came together and changed the law. So now all licensed health workers are protected. So that's 62 different professions for over 500,000 people that did this work together. And similarly, Virginia started this work across the country. Last week, we announced that we have been able to impact over 2 million health workers across the country by removing these intrusive mental health questions across 60 licensure boards and over 1,800 care facilities across the country. So thank you all in Virginia for helping spur this movement for us across the country. So from there, what we did is we brought teams together from the health systems to really centralize well-being into operations. So we brought teams of 10 together that were at all levels of leadership. So it started C-suite leadership, department leadership, accelerators like the IT community as well, to go through leadership training and education on what we mean by the well-being systems approach. If I paused here and each person went around and defined professional well-being, you would all have a different answer because it's very complex and very nuanced and there is no one answer. So this training helped us all have the same language of what we mean by improving the well-being of our healthcare workforce and how the operational environment impacts that. So together, nearly 100 leaders across 12 health systems completed the leadership development and training that really brought to light those barriers to access confidential mental health care, but more so how we can use QI and quality improvement, as well as improvement to our IT systems and administrative work to reduce that admin burden and that cognitive burden to our healthcare workforce. But the learning wasn't just for the sake of learning. The learning was for the sake of action and to accelerate change. And that's what these wonderful leaders are here to talk to you about today. Each of the 7 health systems that are here today implemented quadruple aim quality projects. So that's looking at how EHRs impact the workforce and their experience, in addition to looking at the patient experience and the patient outcomes. And together we followed this approach called WellOps, because we love an acronym in healthcare. And so how do we integrate well-being and operations together? So over the course of the year, these health systems work together as a learning community, both within their organizations and amongst each other, to learn from each other about how do we break down these silos in our organizations to really talk to the clinical teams and the impact of this work, evaluate the current state, learn what's possible, really think about how do we measure a reduction in admin burden or cognitive burden, do the project, produce results, and share what works where it works. And that's why we're here today. These organizations just completed their project, and we want to share with everyone what happened so that we can learn from it and expand our work together. So with that, each one of our health systems here are going to come up and do a WellOps talk, feeling what a TED Talk stands for, and give you an overview of their project, what they learned, and their impact along the way. And so with that, we are going to start. We're going to go in alpha order because that's the only way it's fair, alpha order by organization. So we're going to start with Leigh from Augusta Health.
Thank you, Melissa. My name is Leigh Williams. I am the CIO at Augusta Health, and I have been an ambassador for the Dr. Lorna Breen Heroes Foundation for 2 years now. I think we've had ambassador program, and also in my role as the president of our chapter, as David mentioned, really supports this foundation. I think this is our second golf tournament supporting, and it's been just an amazing journey to watch the foundation over the past few years be so successful. That 2 million mark was amazing, just recently happened. But to hear some folks on this stage a few years ago, I think some of you saw Dr. Simmons give that presentation right as we were beginning our work with it. And then to be where the organizations are today and have this wonderful framework that we followed for our projects has been really rewarding. So I will put out the disclaimer that while I was a leader on the team, there were about 20 people involved in the project. Several of you are here today. So thank you to the Augusta Health team for helping to support our project, which was to implement an ambient listening physician assistant, so an AI assistant. I'll talk a little bit about what the technology is, but then more about how we got it off the ground, how we followed the WellOps program and did the caring for Virginia's caregivers, how we selected that particular project, and then the outcomes that we've had from it, because it has been an incredibly rewarding project for us and is really making a difference within our organization. We looked at projects that we had that were already ongoing, because one of the difficult things when you start off and say, okay, we want to do something for physician well-being, I'm like, you guys are nodding. How do we do this without having to select a project that would need funding, would need to go to governance? So we looked at something that was in its infancy, and we had been interviewing different and looking at different ambient documentation systems, because it sounds great, right? We all get exposed to the fact that, I think, a few things that are assumptions. One, physicians and clinicians are facing a lot of burnout because of administrative burden. Was that the number one reason? Administrative burden. We have a mandate organization-wide to reduce the documentation burden and that administrative burden through our EHR, regardless of specific project. But ambient AI and listening feels like one of those areas that may be a different approach to being able to help physicians. So we had been in conversations with a company called Suki. They are an ambient assistant, AI assistant for physicians. They happen to be alliance partners with both of the EHRs. Isn't that fun? Both of our EHRs that we had, we're currently implementing a new one now. And so we needed to make sure that it would be compatible with every EHR that we might have in our health system. And they won the ticket with being compatible with both our Athena environment and our Meditech environment. So we looked at forming up a project that would value physician well-being alongside traditional ROI metrics. And if you've ever tried to convince a CFO that you should be given some support to be able to do a project where you're going to make the physicians happier and bring joy to their day. The CFO, they are wonderful humans. They love joy. They love seeing, they are not the CF no, who we had the CIS no, the CF no. He wanted to support, but we had to come up with some balanced metrics for what we were going to do. So at the outset of the project, we did there's some really good research out there right now. If you want to read about AI assistant for physicians, there's a lot of good information. We divided our metrics on our balance scorecard for this project into 3 categories. One was productivity and efficiency, that we're going to be a little bit better at closing encounters every day, that physicians will spend less time in the chart. There is the assumption that that's going to be able to drive some volumes, increase access, which is really important for us, and that we'll be able to do more during the day. But that sounds like the opposite of valuing physician well-being, right? Because, you're going to have more time. You can see more patients. Isn't that great? It wasn't how we spun it. It was more, we want to make sure that you can finish your job during the day. So the encounters closed by midnight is one of our metrics that we watch anyway. So that one hit. And then also time in the chart. That's also on there. And then we had a few around coding, billing accuracy. So making sure that our documentation is accurate, complete, and timely to be able to support accurate, complete, timely capture of all the information. The sales folks will tell you that helps you to improve your revenues. I will tell you as an HIM person that all it does is make your revenue accurate, right? So we were just going for accuracy. And there are some tools to help our physicians to be able to make good decisions in the moment. They still retain the authority and the responsibility for making good decisions about their billing. And the third category, here's where the good part comes in, was about physician well-being. So we chose to use there are some different ways that you can survey physician feedback, because well-being is a really personal type of experience, right? If I say to you, how's your well-being? Everyone here's probably thinking, well, how would I respond to that? And I guess I'm okay. I'm happy. I'm not. But it's probably, from a lot of different factors. So we did a couple of surveys. The Mini Z, which is released by the American Hospital Association, is one that was recommended. There are several out there. Happy to share what we learned, but we wanted to be consistent and baseline from before we started with the assistant to now. And it asks questions about, my job makes me feel stressed. It's just a Likert scale. I agree. I seriously agree. I disagree. I have the tools I need to get my work done. I feel impactful and I can make a difference in my job. Things that are related to how they feel about their work. And those sit alongside the coding, billing, and the productivity metrics on the same balance scorecard and are a factor that actually wound up being very important. So we rolled out the technology. So it uses some natural language processing to understand a conversation in a clinic appointment. So if you go see your doctor, you can say things like, oh, my kid's soccer game was fantastic on Saturday morning, but later that afternoon, I was playing soccer in my backyard and I kicked the ball and fell over and hurt my knee. And the doctor will say, you know, which knee? And you say your left knee, and all of these details. And you just talk. They're allowed to visit with the patients. The provider does not need to be typing. They are having a conversation and doing the work of understanding and caring for that patient. And meanwhile, there's an iPhone app or an Android app that we use that's sitting there listening to the whole conversation. We do get consent from the patients at first to say, are you okay with me recording? And about 98% of them say, yes, they are. And then the system listens, natural language processing. It uses some large language models and gives the physicians back at the end of the session a draft of that encounter. And it helps them to be able to start from something other than scratch. So I don't know if you've ever thought about, okay, what if I saw 10 patients today and you don't have time in your schedule to do your complete documentation before you finish, and now you got to go back to the first one and remember all those details. That cognitive burden of trying to remember everything, I couldn't do that if I was trying to do it with a meeting I had today. I mean, if you think about that, if you had to go at the end of your day and document everything accurately, timely, and completely for your whole day, it's hard. They really love it. They have a first draft. They still have to read it. They have to parse it. They have to sign off on it. But we were able to move important metrics. Our well-being metrics are all showing trending good. We did a pilot for 12 people for about 3 months, and it was a good enough response from the physician community that we decided to invest. This technology is not cheap, but we've figured out that while it's not necessarily driving a lot of productivity, now we did not set out to say, so you get to work more. That was not part of it. It was just, let's see how this impact is. Our physicians, I have 2 favorite quotes. Dr. Snodgrass, who's in primary care, said that this is the first time that technology feels like it's being done for me as opposed to me. And I thought that was fantastic because for years I've been a technologist and we do a lot of technology to clinicians, right? So for me. And then Dr. Porter, who's a surgeon, said that he was going to push out his retirement date because he could see working more years with a tool like this, whereas before, didn't really want to have it. So we are now in the process of rolling it out organization-wide. It'll be incorporated into our EHR going forward. It is a big investment for our organization, but we feel like the benefit that we've gotten from being able to take off in a meaningful way some of that administrative burden has been a real win for our providers, which is a win for our patients and our community as well. Good? All right.
Thank you, Leigh. So next up, we have Richard from Carilion Clinic.
So first off, I just want to say, anyone who's had a hand in rolling out ambient scribe technology as a physician, I would just like to say thank you because it's definitely changed my life of my colleagues. I had the privilege of taking my family to Busch Gardens last night. A 10-year-old, I have a 7-year-old with autism. They're going to ride their first roller coasters. Let me tell you, that's like health IT in a nutshell. It's just pure chaos. So hang on, enjoy the ride. Now I'm going to switch gears. I'm going to talk to you a little bit something simpler. We're going to talk about changing the preference list in our EHR Epic or whatever you use. So my first question to you is, what is the value of a mouse click to a physician? What about a mouse smile? You ever considered that? Think about the countless interactions that we have with the EHR every day as a physician. We order labs, we order tests. We have to interact with this every single day. We document visits, right? Either typing or if we're lucky to have ambient scribe, we do that. We review labs. Just a little click here, an extra click there, a little mouse travel there. Doesn't sound like much, right? Until you realize this is happening hundreds of times per day, day in and day out. Over a career that becomes millions of clicks, miles of mouse travel. See, these clicks, in my opinion, they're the silent tax of technology. They don't show up on a bill. They don't get tracked by leadership in the EHR on some fancy dashboard. They don't look at that. But physicians, we feel them. Every unnecessary click's a tiny drain on my focus, on my energy, on all of our time with our patients, with you, the people we care about. So our physician builder team and I asked a very simple question. What if the system could just be a little bit smarter for us? And so we did something simple. We looked at the most common medicines that we ordered, just 150 of them. And we did something very simple. We preset the defaults to the most common things that we change them to. Correct doses, correct dispense sizes, the proper instructions, the SIG on it. That's it. No new technology, no fancy tools, no vendor. Just thoughtful tweaks to the defaults physicians see every day in the EHR tool that we already have, Epic. So now what happened? Now keep in mind, our project is not finished yet, but I got some preliminary data for you all. We planned on a 3-month measurement cycle. We are into week 7. We got our Epic preference list tune-up tool. It's actually yesterday they got it to me. And our measurement point at the 7 weeks mark is as follows. Before our changes, physicians averaged 1.3 changes for every medicine order that they put into Epic. Afterwards, that dropped to 1.14 changes per order. It's a 13% reduction in just 7 weeks. So let me put that into numbers for you. So in less than 2 months, that meant 18,559 fewer clicks. That's thousands of clicks gone. But what does that actually mean? It means hundreds of clicks saved every single day across our health system. It means meters of mouse miles traveled that won't be traveled. Doctors literally walking their mouse miles across their desk, right? We don't ever think about that. It means minutes reclaimed in all of our days, which rolls into hours saved every year. For an individual physician, it's about 10 clicks a day when you do the math from what we have so far. And that doesn't sound like much. It sounds quite small, actually, until you multiply it by every provider in your organization, every day, over a year, and then it becomes massive. And when you look at the enterprise-wide impact, folks, it's around 89.4 hours per year just in saved clicks and mouse miles. Let that sink in for a second. You see, folks, to me, this is not about efficiency, it's about dignity. Every unnecessary click is a theft of our focus that we want to give you, our patients. And when we fix these little things, when the system finally works for us, we don't just give back seconds, we give back clarity, give back energy. We restore the joy in the practice of medicine, being able to sit down in front of a human being and treat the patient, have a conversation, and understand each other and connect. And so, what is the value of a mouse click? Alone by itself, it's not much, but multiplied by every physician, every order, every day. The difference between burnout and balance, between frustration and focus. And sometimes I would say it's the most powerful way to change healthcare isn't with something shiny or new, not necessarily with artificial intelligence or augmented intelligence. Sometimes it's just by making the everyday things that we do just right. So dream with me a little bit. Look at what you're already doing, what you already have in the system. Tweak it. Listen to your physicians. Listen to your nurses. Look at their workflow. And just go forth and make it right for them. Thank you.
Thank you, Richard. Next up, we have Jenna from Centra Health.
Thank you. My name is Jenna Dziuba. I am with Centra Health in Lynchburg. So I was prepared to say that for myself, and you threw me a curveball. I am here today. Much likely, I came in to this project brought in by our wellness guru at Centra to participate, ready, guns blazing to do something really cool like ambient AI. And then I thought about, well, we're not done with budget yet. Are we going to have the resources? I don't know. So, much likely, we leaned on something we were already starting to work on. And I think I'm really just building off of everyone here. But I assume all of you keep a really good, close eye on research around patient safety in the healthcare system, correct? And clinicians? Maybe somebody doesn't. So I will tell you in 2010 or so, we started seeing a lot of literature about alarm fatigue. 2013, the Joint Commission comes out and says, we need to do something about this. This is a national patient safety goal. In my hospital, and probably many of you, we instituted an alarm management committee to look at alarm fatigue and see what those things are. We meet once a year, sometimes a little more, depending on what's going on. And we all sit in a room and we argue about all the beeps, the boops, the wee-oo, and how frequently they should fire. We call our vendors, when we think that something's too sensitive. And we really try to decrease that burden because it's all noise. How many among us have heard the noise of healthcare? You don't hear that. You know it's a wound vac alarm, but you don't hear it. You hear that vent alarm. And, once you've been in the hospital for a while, you say, well, they probably coughed. And it's noise. And it takes a second. It has to keep going for you to go check. And we know this. We work on this. And like I said, many of you probably do. Who has, though, a management committee around alert fatigue? Hello? We got somebody ahead of the curve here. We hadn't. And we got to looking in the background of our EHR and looking at all sorts of things because that's what informaticists do in applications. Probably maybe was born out of a comment made in rounding at some point, but we got looking and in a list, I love to show the picture of this slide, but I wasn't allowed to. So I'm going to set a little bit of a visual tone if you need to. In January 2024, I snipped a bar graph of the top firing alerts in our system. There were 13 on that first sheet. The first 3 fired combined 5,000 more times a month than the 10 that came after it combined. 3 alerts, 215,000 fires in 1 month. And that's to nursing, providers, CNAs, respiratory therapists, a whole different group depending on the alert. So we took them, my awesome informaticist over there, clinical applications, they're over on that side, y'all can wave. And we went to it and we looked at it and we said, why? If this alert is firing 88,000 times a month, what's it alerting? That somebody, coughed? What's going on here? So we went back and we were able to work with our teams, leverage our folks who have been around for a while and had some history, get into the subject matter experts of accreditation and licensure or patient safety to say, hey, tell me more about this. What's the why? And so we were able to dig in. In one instance, it was an alert that goes to our nursing staff to say, hey, this med may be new. You want to educate your patient. It's well-intentioned. It's benign. The problem was it wasn't specific, and it would fire for brand versus generic names. It would fire if someone had taken metoprolol since 1962 because there was a new med on their admission. It didn't know. And so we got to talking, and is that the best way to handle that? It's not required, which is what everyone thought it was. And I'm guilty of this when my team said, hey, what do you know about this? It's a regulatory thing. It wasn't. When we really got in and dug into it. So we looked at it. We were critical. We said, does this make sense in the workflow? Does it need to pop up right in the middle of medication administration? So I'm in the ICU and I'm mixing Lido. Do I need to know that I need to educate my patient on it right now? Sorry, Lido, Levo. Sound like a real nurse now, don't I? I don't need to educate my patient right now because I need them to have blood pressure. And so we took that out of that workflow. We moved it to a place that made more sense. And the crux of it is still there, but it's not impeding the workflow. It's more specific to what the nurses are doing. We did something similar with an alert in our ambulatory areas that everybody in our ambulatory teams received. And it was, again, well-intentioned in 2018, but no one had ever taken a look at it to say, why? Do we all get it now? It was an alert to warn people about a new feature to make sure they went and checked something 6 years ago. Not needed anymore every day on every chart. So we pulled that out. We found a better workflow on top of that and educated to it. And that was our 88,000 alerts a month for that one little box that no one had ever questioned. It's a learned helplessness sometimes. And so that's what we've been doing. We've been walking through, looking at these alerts, looking at them critically, and we've come to the point where we've put guidelines in place. So who has been in a patient safety meeting and the first thing is, we need to put in an alert? Yeah. Or if it's not, we need to put in an alert, we need to educate them. That's what it always is. Those are the two answers. So we put guidelines in place so that we can come in and say, all right, is that alert actionable? Is it driving the clinician to the place it needs to for them to do the work? Is it changing their action? Do we have a measure of success to prove it is? And if not, what are we going to do to come back around and look at it again? And so we've really tried to socialize that idea with our informaticists, our applications teams, our IT shared governance for EHR changes, and have those conversations. And so I have not put in, I'm looking at Yolanda, I haven't seen an alert come in recently that we've put in. So, we're really making people think critically about that. So my takeaways here for you guys from what our work has been, one is, to Richard's point, everything doesn't have to be a production. Everything doesn't need a capital request, a budget request. Everything does not need 1,000 resources. We can eat the elephant a bite at a time because it's a big elephant. We can look at change because incremental changes change, and it's all adding up to the tune of knocking out 3/4 of the alerts that our ambulatory providers, nurses, docs, MAs see. It is knocking out 52% of what our inpatient staff sees just by looking at it critically, asking the right questions. And so I encourage you to build strong relationships with your clinical teams, with your informaticist if you're on the clinical side, and have that spirit of inquiry, have that culture of curiosity and safety to ask and to get those answers and think about it and see what you can do in those small moments. Thank you.
Thank you, Jenna. All right. Next, we have Eric from Children's Hospital of the King's Daughter.
Thank you. What tough acts to follow. So I'm going to take a little bit of a different tack for a bit here. Health, healing, and hope for all children. That's the mission statement for Children's Hospital of the King's Daughters. We are a children's hospital that takes care of roughly 500,000 kids and requires an enormous workflow of pediatric healthcare providers. And not just providers, all healthcare workers. And I want to kind of focus on that a little bit as to where we went with this project and what we're doing. So to do that, just to give you a little background. As I mentioned, we're a freestanding children's hospital. That means all of the revenue that comes in has to be pediatric healthcare. Those of you who have been paying attention to the news lately know there's a lot of challenges right there. We have a full suite of services, including a new mental health hospital with 280 beds, $280 million health hospital, 60 beds psychiatric hospital. Huge healthcare need. Mental health services also not well paid for, and there's a huge crisis in pediatric mental health care. So let me tell you a little bit about the workforce, because we're a highly matrixed organization. We have 4,000 non-provider workforce members that are deployed across the region. We have probably around 500 or more, no, we have more than that, almost 1,000 healthcare providers, general pediatricians, pediatric surgeons, pediatric subspecialists, all of whom work in different organizations. Some work as subsidiaries of the hospital. I am Chief Quality and Wellness Officer for Children's Specialty Group. We're about 380 pediatric subspecialists. We are not employed by the hospital. We are a separate LLC affiliated with the hospital. In addition to all of that, we have a relationship with the medical school. So we are the primary educational force for all of the pediatric care, both physician and non-physician. And we are the full-time faculty for Virginia Health Sciences. So we have the academic role as well. And the headwinds. I don't know how many of you know. So for instance, for pediatricians, over the last 5 years, the percentage of medical students choosing pediatrics as a health career has dropped by about a third. And most of that is all about dollars. So that's kind of the background for where we were with this. So from an EHR perspective, for our health system, we have a multitude of interfaced healthcare software. In particular, our EHR has been Oracle Cerner. Our ADT system has been Allscripts, Eclipsys, and our practice management system has been Epic. And that creates a lot of challenges, in particular, as we go to do the data analysis and helping our healthcare workforce. Having to deal with all of the different tools has been a challenge. So we came into this with a goal of ultimately optimizing our healthcare IT systems to help manage all of these patients and improve the workforce work life. We put together a team that included IS, obviously, quality. We had physicians, nursing, project management, and patient care services. And we went to evaluate our current state and get data on all of the kinds of things we've been talking about, right? How many clicks, how much time in documentation. We found out we have real challenges getting data because of the way our our IT is structured. So we actually worked on that for a while and got some success. For instance, we're part of the Joy in Medicine as well. How do you actually measure ambulatory time and normalize it to 8 hours when your schedules are on a totally different system? We were able to do a little bit of that, and we got some data, and I think that was helpful. But ultimately, the health system decided it was time to actually figure out, how do we consolidate into a single system? So while we took a look at our data and we found that within the EHR, we have tremendous variability by provider, we found it didn't actually correlate terribly well with who was getting the encounter closed by midnight. So at the same time, we also have done an AI tool, an ambient listening tool pilot, and found that it was useful for some, maybe not useful for others, and also varied by visit type. So we're working on that as well. But ultimately, we decided that we needed to figure out a way to consolidate into one healthcare system, one EHR practice management ADT system. And it was recognized that if that's going to happen, IS is essentially going to be all hands on deck doing that. So this was not the time to say, hey, we want to do this little project and this little project and change this, because quite frankly, their hands were full. So that is just about finished. And I anticipate we're going to have a decision very, very soon. And then we'll start forward with that. The other thing I'd like to also talk about, maybe we'll do that a little bit later, but making sure that these kinds of activities are interfaced with other activities that you're doing in the workforce. So it's not all about the EHR. Stop there.
Thanks, Eric. So we're gonna swap panelists now because we couldn't all fit on stage at once, and these faces will be back. Feel free to stand up and stretch if you need another stretch break. And we are going to start with Lindsey from Inova.
All right. Can you hear me? Okay, I'm Lindsey Stanton. I'm Associate CHIO for Ambulatory at Inova, also practicing FNP, DNP, and primary care. Still see patients every Wednesday. I'm sorry, I'll miss Wednesday's session. Who here works in ambulatory as a clinician? Anybody? How much do you love your in basket and how much time you spend responding to patient messages, requests, tasks? I think that is a general problem across all of ambulatory care. So one of the big things at Inova we were working on, and again, we chose a program that we were kind of already starting on to focus on with this project. So we were looking at how much time and effort and how burdened our staff felt by those messages. And so we're trying to reduce that effort and reduce that cognitive load. And so we went forward with introducing augmented response technology. And if you haven't heard of that yet, basically it's Epic's version of an AI large language model called ART that reviews patient submitted advice requests and then runs them through a large language model and generates a drafted response. And so the clinician, when they're responding to those patient advice requests, you have a place to start from. And so it responds in the tone of the healthcare team and writes out a draft that you could use. You could edit it. You could not use it at all and use a quick action or some other already quick and easy tool to use. And so we implemented this with about 110 providers, physicians, APPs, medical assistants, RNs, LPNs across a bunch of different sites at Inova. And kind of gave a little bit of time just to experience it, train with it, use it, and then we went back and we reviewed their feedback. We made a few adjustments to our prompts. Basically, like it has 4 categories: general, letters, medications, and results. And our medications feedback was really bad, right? Like it had so many thumbs downs. And basically, it wasn't giving a full kind of explanation about medication and giving any kind of like patient guidance or education about the medication they had the question on. So we adjusted our prompts and did another couple of weeks, and suddenly our feedback went sky high and it had like a 75% satisfaction rate. And so we did a little bit of that iterative process. And Tracey, who's here, was our nursing informatics fellow. She did the same Likert scale testing on the people who are participating before and after. And, we saw significant improvements and, feeling like they had the tools to do their job, feeling like their burden was reduced, feeling like they were able to accomplish tasks quickly. Specifically, bit heavily impacting medical assistants, but we also saw those same kind of trends in LPNs, RNs, and physicians and APPs as well. So really, really well, liked. So the Epic average utilization of this is about 20%, somewhere between 15 and 20%. And our most recent month, we had about 14% utilization. So every message gets a draft, and then you can choose if you use it or not. And that sounds low, right? Like 20%, you're only using 20%. That doesn't sound very good. But the thing that this tool does so well is responding to the more complex question, right? Like not the thing that's like, okay, thanks, sure, I sent you that thing, I'm done, right? That's easy. We have a quick action for that. We have a button for that. You can do that without thinking. You probably don't need this technology for that. It's the patient that sends you a message that's a paragraph long and you have to write back some, extensive, thoughtful response to a multifaceted question. Those are the things that take the longest, and those are the things that cause you the most cognitive burden and administrative burden. And so that is the place where we saw the highest yield. And so at one point during the pilot, I was in a break room chatting with about 8 medical assistants who had this tool and were testing it for us. And I was like, okay, how sad would you guys be if we didn't go forward with this? If we just it was not going well, we're just going to turn it off. And they were like, no, please don't take it away. I have to have it. I can't live without it now. And we get emails all the time what's the scaling plan and when is this coming to my office? Because I've seen it and I've heard about it. I watched it talk about it. I really would like it. And so I'm happy to report that we're going to be scaling to all of ambulatory in early 26. And it's been just really, really satisfying to be able to give that time back. And in our pilot, each people, sorry, we saved about 22 hours of time because patients or providers, no, sorry, not patients. The people who are participating, the pilot participants, are saving about 28 seconds per message. And when you multiply that over the entire pilot, it was about 22 hours of time given back. And so that's your time at the end of the day. You might get to go home a little bit early. You might spend a few more minutes in the room talking to someone because you know you're going to be able to get through your in-basket quickly when you get back to your desk. And when we start thinking about cost, this is really, really affordable. It's 2 cents per compute. And so the compute cost that we spent for this pilot was like $400. It's going to cost like $3,000 a month when we do it for all of ambulatory. So when you think about return on investment, if you're giving people back 28 seconds per message for that amount of money, you'll be able to get your funding. So that's it.
Thank you. Now we're going to hear from Greg from Mary Washington.
All right, well, let me begin with a quick observation. If you've ever watched professional athletes at the top of their game, whether it's a golfer thinking that great putt or hitting a great shot from a horrible lie, or maybe a basketball player who hits that buzzer beater to win the game, or a tennis player who hits that perfect serve to ace, you'll probably hear them talk about those moments as a perfect shot. They describe it as hitting that perfect shot when the mechanics and the preparation and the timing all comes together seamlessly. It's a rare feeling, one of effortless excellence, where challenges of competition feel surmountable and the athlete is in harmony with his or her environment. And right now, that's kind of how it's starting to feel in healthcare IT. There's a lot of things, pieces, finally coming together. And instead of just struggling to keep up, we're starting to find that sweet spot where technology begins working for us, not against us, and for our end users, our clinicians, the joy of practicing medicine, right, can begin to shine through. I'm Dr. Greg Szlyk. I'm the Medical Director of Informatics for Mary Washington Healthcare. We're a small not-for-profit organization in Fredericksburg, Virginia. And I'm going to share a story with you today, not just about technology, but about transformation. Like many health systems across the country, we've really begun to feel the weight of provider burnout, long hours, documentation burden, the emotional toll. It's real, and it's why we partnered with the Dr. Lorna Breen Foundation, whose mission is to protect the well-being of our healthcare professionals. As part of the Well Ops program, we were challenged to identify an opportunity in our organization where our clinicians work every day. And as we found out, and much as we would like to believe that our clinicians find great enjoyment from using our EMR, the truth is that most still view technology as an impediment to efficient clinical practice and often as a major contributing factor to burnout and dissatisfaction. So we asked ourselves, what can we do to alleviate some of that burden? And as it turns out, as many of my colleagues as part of this project realized, that we had projects underway that if we just focused a little bit more on physician satisfaction, we could apply them in a very meaningful way for our users. And we were working on ambient scribe technology as is Augusta Medical Systems, and we used our pilot and our ROI type endeavor to launch a trial for ambient scribe technology in our multi-specialty organization, primary care. So you all have heard the description of ambient AI. It listens to the conversation that occurs during the visit and drafts a note for the clinicians. I don't need to get into that right now, but I'll tell you that we selected an initial group of 17 providers representing various primary care and surgical subspecialties. And our initial user group was very diverse with a wide range of technical and EMR prowess. And we did that intentionally because we want to field test this technology sort of under real world scenarios. supporting this rollout, some of whom are here today, as part of the Caring for Caregivers initiative, was a small team of informatics leaders, executive sponsors, managers, and clinical quality representatives. And here's what happened. We surveyed our 29 providers, our 17 providers, and as I'll tell you a little bit later, we kept the survey open later because we've rolled out the program to many more. But we found that 90% agreed or strongly agreed that this technology, DAX, improved their efficiency during patients' visit. And it's a real lifesaver to some. We heard from many of our clinicians during physician feedback forums that they felt like it gave them their life back. They were able to get home to spend time with their kids and their families and finish their notes early in the day without the administrative burden of writing notes. Of our 17 initial users, 14 were above the 50% in time spent in notes. And most saved an average of 5 minutes or more per encounter, some up to 20 minutes. And in the course of the first year, we logged almost 20,000 encounters using this technology, which is 100,000 minutes of time saved just in our 17 providers. Clinical notes saw nearly 75% improvement in the quality based on documentation, fewer errors, more confidence, and more detail around the subjects that were being discussed with patients, many of which were forgotten previously because in the effort of just getting through the course of the day, documentation tends to become less specific and you lose some of the details. Patient interaction. Over 69% felt their patient interactions were enhanced because there wasn't a computer in the way in the room. 86% reported a reduction in mental strain during documentation, reducing the cognitive load. And that's real. That burnout, that cognitive load that you have to shoulder as a clinician pulls away from the amount of empathy that you have for your patient. And we're all patients and we want our providers to be empathetic. But when they're straining and struggling just to finish the documentation, that has to come from somewhere. 83% said that DAX positively impacted overall care, and 82% felt more satisfied with the EMR. We didn't expect that when we asked that question. 83% felt that the EMR was better because of this little tool that we added. Some of my colleagues talked about same-day note closure. We did see an improvement. 50% of our users were above the 50th percentile in same-day note closure, and 10 of the 17 were in the top quartile for their peer group. We use Epic, so this is judging them against their specialty peer group using signal data. We also asked them if they felt that this type of technology could potentially improve our recruitment and retention of new physicians, and 83% agreed with that statement. So although we're focusing on note closure and clinician satisfaction, there's spillover to other areas that are going to be beneficial to sustaining our workforce. These aren't just numbers. Behind each one of these numbers is a story that a clinician told or is sharing with one of their colleagues, and the word spreads. We're now working on rolling out this technology across our entire multi-specialty group. We're broadening that rollout to include departments, both outpatient and inpatient. We're also bringing DAX to some of those specialties where we didn't think that there would be a lot of adoption right off, like orthopedics. Some of our highest users and most satisfied users were in the orthopedic specialty. Those type of doctors are notoriously hard to please from an informatics perspective. So we kept our survey open. And this is probably a good point to bring up to the group here, is those surveys don't just help us look at metrics, but they also help us dial in our delivery, because you can see where the dissatisfaction is coming from. You can see the clinics who might need some help with their super users. You can see those departments that might not have tweaked the tool, whatever it may be, to their satisfaction. And when you see those poor reviews coming in, you can sort of adjust your tactic, your strategy to help support those clinicians, to help your delivery be better. So our message to our users, we're trying to be pretty clear that this is not only something that's designed to help with same-day no closures, but it's more about physician well-being, more about leveraging technology in a way to help our providers instead of putting another thing on their plate from a technology perspective that's just going to burden them even more. So thanks to the Dr. Lorna Breen Foundation. It's been fantastic. I'll pass it on.
Thank you, Greg. Okay. And next we have Tracey from the University of Virginia.
So I'll give you one guess to guess what I'm going to talk about. Anybody know? Okay. So I am going to talk about the University of Virginia's ambient listening journey. But I first want to give a nod to all the panelists up here for all the hard work that you're doing. As a former ICU nurse myself, alert fatigue, clicks in the EMR, preference list work. My journey, just to tell you, started out on paper and very quickly took my job at UVA because I went to a unit that had an EHR. So now let me tell you who we are, a little bit about us, and the impact that we're making. So we are a 4-hospital system. We are one academic medical center hospital. We have a children's hospital in our system. We have little around 1,000 beds. We have a designated cancer center, around 190,000 patients treated in our ED. We're a level 1 trauma center, over 3,000 physicians and APPs, 18,000 team members, 50,000 inpatient admissions a year, around 50,000 surgeries, 1.3 million clinic visits, and 23 licensed pharmacists. So why do I tell you that? Lots of opportunity for burnout, lots of work and hard work from our clinicians and our providers. And so what did we think would be an approach for us to help with burnout? So we went on our journey with our partners, Microsoft DAX, and we thought this would be important because our providers had identified quite a bit of burnout, burden from documentation, same things that we've heard from Leigh and Gregory about that experience, the administrative burden, number one driver for provider burnout. Burnout creates turnover. Turnover results in access constraints and erodes the experience for our patients and our providers. So what was our guiding North Star? Give providers time back at the point of care. Enhance that provider-patient experience. Make it more interactive, not so with our backs turned to our patients, which we had kind of moved towards. Primary care providers had reported a high cognitive strain. Our pajama time, I'm sure we've heard the term pajama time, but time spent after work, we wanted to decrease that. And then providers desired a high quality patient care and wanted to create access to create additional documentation or decrease that burden. UVA, where did we start? So we started at the bottom 25th percentile against our measured pajama time. That's across all the EPIC organizations. That pajama time's your average time spent in the chart, 7 a.m. to 5:30 p.m. on weekdays, and then time outside of schedule hours, holidays, and weekends. So what did we require when we were looking for our solution? So we wanted a highly engaged partner, one who put our providers and clinicians first, which we found that with the solution that we had. We wanted it to be fully integrated and seamless with our healthcare. Leigh referenced that with her health system. And we wanted our patients' experience at worst to remain untouched, but with the goals that it would also be an improved patient experience also. It needed to be scalable across our health system. And we wanted to show potential to support the providers and specialties beyond primary care, which we did. And we are talking about providers, but I'll speak to the fact that this goes beyond the providers. It's everyone in our health system that provides clinical care. But most importantly, we wanted our providers to like it. I think I heard a theme so far that don't do technology to me, have it help me do my job. Heard that over and over again, and it matters. For instance, when you mentioned mouse clicks, you was like, what does that mean to me? I remember providers counting clicks to time, down to revenue. However, that resonated, and that was a comment made to me back in 2009. I'm not aging myself there, though. What was our case study? So UVA rolled it out to volunteers. I believe I went around and begged to get 10 users. 10 users. Pam, who's here, she knows how that was with us. We wanted to do quantitative and qualitative data to capture from our participants that would inform our next steps. And then the pilots were supported by the technologists, clinical trainers, informaticists. If I give a nod to Wendy for keep your informaticists involved, highly valuable. I'll speak to that a little bit later. And we had town halls. We did user meetings. We had our pilot study people. It was small, so they had direct access to the team. They had direct access to the leadership, to the vendor, to everyone. So it was a very much a team effort. So what were our quick wins? Providers in the pilot immediately reported satisfaction and improved experience. Qualitative data told us the following. So I'm going to read a couple of quotes. This can say primary care making documentation sustainable for a career. I think we heard that theme earlier. Now I can simply dictate my thoughts as I leave the room, and DAX does a good job capturing and not simplifying or revising my monologue. The Microsoft customer support and response to feedback was excellent. The pace of improvement and innovation is fantastic. And then my own personal PCP said to me as I got to participate as a patient, I get to go home and watch Jeopardy now, and I know who wins. So I thought that was the most amazing comment. Let's see here. Let's say our quantitative data was also promising. There was surveys, independent study conducted by Jinjing, Leigh, and Sarah Lebovitz from our McIntyre School of Commerce. Huge research project. So there was survey information from our vendor, but we're doing an independent study for right now. But what improved? Provider well-being was reported improved. Work-life balance was increasing, and providers were suddenly more satisfied with their EHR workflows, which is, I think, what Gregory reported also. So we have a theme going on here across our organizations. How did we make it stick? Based on the promising outcomes of the pilot, we knew it was time to scale. So whereas I had to beg 10 users to be in this pilot, we were quickly at a point to where our BOGO with Microsoft, I had exceeded the number of license, and we moved very quickly to an enterprise license. We have over 1,000 users enrolled now. Let's see, and then the providers were so more. Told you that. So we established an AI ambient listening steering committee. We had that steering committee from the beginning. One of the key leaders in that was Dr. Steve Borowitz, pediatric GI specialist, and we actually started in specialty and primary care with our 10 pilots. This was his vision that he had been working on for many years, and we were so happy to bring this on board right at his retirement. So he got to be he continues to be part of this and champion this with us. Again, an informaticist, maybe not by job title, but by all the work that he's done in the space. He was a physician champion back when we implemented Epic. So keep your informaticist close and handy. Let's see, I mentioned we signed our enterprise license. The solution providers using it supported, we had a strong vendor partnership. When I talk about scaling, we have pharmacists who want DAX. We have nursing who want DAX. We have physical therapists who are piloting DAX. We have case management. So when we talk about caring for caregivers, we can really scale this across the health system. So outcomes that matter, time and notes decreased by nearly 9%. This time was went directly back to the providers. Same day closed appointments increased by almost 10%. So we had a little bit of gains there. Provider well-being scores increased by 16%. So our providers were happier doing their same work. And happiness at work matters. I mean, it matters to all of us. Providers workflow satisfaction measured of satisfaction with the EHR jumped 24%. Documentation satisfaction saw the biggest jump with an increase of 47%. And again, this was part of the independent study that was completed, and it was based off of 302 active DAX users tracked over 34 weeks over a 6-week rollout. The model accounts for each provider's unique practice patterns, weekly variations, and wave level differences. 187 providers completed the survey 1 week within the DAX when DAX became available, and 135 completed in 6 weeks post DAX. So what are we doing next? So I'll talk about what we're going to do with DAX, but in general, generative AI to help with well-being of our clinicians. We are actually rolling out ambient listening to our learners. So we have around 300 residents and fellows in our ambulatory space. We're still trying to work through at what point's the right time to give a tool like an ambient tool to a new practicing clinician. But we have great partnership with our operations team. We have our physician, our CMIO, Andy Markowski, who's helping drive some of those discussions and decisions for us. Let's see. We are working with our vendor to identify additional tools that can be helpful. So we've also looked at inpatient DAX for nursing, which utilizes, so if you're not an Epic shop, Rover is their mobile device. We're looking at, and we are also planning, I'm not going to give away the date, but very soon our inpatient rollout to our providers. So a lot of our ambulatory providers practice in our inpatient space. So some of them are already picking it up and they realize that they could use the tool and they're loving it. So our vision is to be one of the nation's leading public health systems and best place to work. I think having some of these tools are very enticing to folks. How do I work smarter, not harder? That's an old saying that's still applicable today. And just looking at any other locations that we can utilize our ambient tool. So takeaways. What did we learn? You need to start with something you can measure. You've had some great examples today, but think about what matters to you, your organization, to your providers. I think there's always additional positive outcomes. So like maybe revenue, maybe increased visits. But again, we too didn't sell our ambient listening tool that way. We wanted to make it a better experience for our providers and again, our patients. Let's see, make automation the default. So co-design the solution with your clinicians. Again, as an IT, we don't want to do it to our clinicians. We want them to come along beside us and help drive those decisions. And it makes it much more impactful for our teams when we embrace that approach. Share your outcomes, which is what we're doing here today. There's a lot of new information that I've thought about that now I'm going to take back and incorporate into the work that we're doing. So thank you for that. Consider increased cost up front. So if Microsoft taught us one thing was to figure out your, for lack of a better way of saying it, your reimbursement solution. So we have an enterprise license. I just want to give it to everybody. We're made up of multiple organizations within one organization. So we're still trying to work through that, but we're making a lot of progress. Have your steering committee. It's very important to have your leadership, your executive leadership at the table to help you with your CFO go. Whoever said CFO no, that made me giggle. But our CFO is very supportive of this tool. And then be creative and brave when you're improving, your provider's experience. I wrote down some things from Wendy earlier. So be creative, innovative, brave, have your informaticists, and it goes back to being human-centered. So bring all those principles in. And then we wouldn't have made this possible if it hadn't been for our CIO, Robin Parkin, who will be here later today, Mike Nevada, who is my direct supervisor, Andy Markowski, our Chief Medical Information Officer, who came along a little later in the project. What a big difference that made with expanding this. Our training team, who did a tremendous amount of work, our partnership with our vendor, who provides a lot of support, and then, of course, the analyst, Epic teams who help implement all this work. So thank you. And I hope the third time wasn't too much for ambient listening.
So we're going to spend the rest of our time with discussion. So we're going to start off on stage with Eric, Tracey, Leigh, and Greg for our first discussion, and then we'll have the rest of the crew come back. Okay, so we heard a lot about how the link between professional well-being and quality and safety. But as we know from these conversations, it goes a bit further and it's related to workforce retention. And so we want to hear a little bit about how your efforts directly supported that. And I'll start with Eric.
Well, thanks. So I think when we talk about workforce retention, and I mentioned how important that is for our organizations. The first thing you have to do is measure it. I don't know that how many institutions actually measure each component of their workforce to know what your turnover rate is. So if you're not doing that currently, I would encourage you to do it and also take a look at what it's costing you, not just in terms of the recruitment costs, but what are the costs of the environment, the missed appointments, the workflow stress, et cetera. The other thing I was going to mention, I mentioned this before, is focusing on integrating not only the EHR and the other administrative burden work, but also what else is going on in your workforce retention. So, for example, one of the factors that's really important in maintaining and decreasing turnover is leadership. What are you doing to promote leadership? What kind of leadership development do you have? 2, what about career development? When people come to your organization, what's on their career bucket list? And are they able to achieve it? And if that changes over time, are you flexible enough to meet those career aspirations, or do they have to go somewhere else to meet them? Another way to measure, so for instance, in the mini Z, which I think was referenced earlier, there are questions like, what would impact your likelihood of staying with this organization for the next 3 years? Or what would impact your willingness to not cut down, they word it a little differently, but to not cut down your work hours, to continue to do your work hours? What are the answers to that? And how's your organization looking at those particular factors? And lastly, when you're measuring, I think most of us are looking at the people who left and why did they leave. We do exit interviews. We get an assessment of that. I would urge you to take a different focus on that. Look at your best people and find out why they stayed. Thanks.
Thanks, Eric. Tracey, what about you? How is your efforts in well-being directly supporting retention and recruitment?
So not to be redundant and what I had just mentioned, but having clinician buy-in creates an opportunity for them to have a meaningful impact into how they function on a daily basis. I believe it increases work-life balance, and again, easier access in the chart makes it easier, reduce the cognitive burden for our clinicians.
Thanks, Tracey. So to switch gears a little bit, would love to hear, Leigh, starting with you, what surprised you the most being part of this community? And is there something specific that you're taking away for future work and impact?
For our foundation work, it's been amazing how similar the challenges are, that they translate across large organizations, pediatric, geriatric, rural, urban, et cetera. We're all facing the same challenges. And I have absolutely loved how we're all, whether we're pumping $1 million into an ambulance solution or you are doing some alert fatigue work, which I wish you had the slides because your bar graphs are amazing on that of how it shrank down, that we're all facing a lot of those similar challenges, and the focus on what can you do, start where you are, do what you can, right? That it is all about making actionable choices. Whether, like I said, we already had this project in motion, I was like, hey, that's the one. Or what can we do that is actionable today? So having the group to be able to think together and getting excited about ooh, alert fatigue. And it just seemed, I love the one from Centra because it seems so simple and yet it had a huge impact. Or there may be some things that are bigger, like what you were talking about with UVA and the 1,000 providers that we're all in it together and that it takes the actions large and small. I have really enjoyed that. And thank you to the foundation for giving us a great structure. They use technology very well to make it easy for us to communicate with each other. So I've enjoyed not only getting to know the colleagues, but also appreciating how much we share in common of this really massive problem to solve.
Thanks, Leigh. Greg, what about you? What surprised you the most, or something that you learned that you're taking away?
Well, I felt that the community was very supportive and very encouraging, especially around the discussions that we all have around data and metrics. And sometimes it's daunting, no matter how big or small your department is. When you go to do a project, everyone says, "Oh, make sure you find some baseline data that you can and look at." But we don't always do that as well as we should. But this, the community, this forum sort of forced us to kind of go through those motions. And when we looked at that data, we found not only the opportunities that we had for this project, but 2 or 3 others that we probably would have overlooked had we not really looked at. And in Epic, it's called signal data. And I think it's probably under leveraged, underutilized by most organizations. And the process here, that's sort of surprised us that if we just do that due diligence, we uncovered a lot of opportunities. And I think that helped us be more successful.
Well, before we switch to the next set of panelists, is there any questions from the audience? We could take a few.
Hey, Tracey. I'm also Tracey from Inova. I was just curious, you talked a little bit about or mentioned the concerns about ambient with new clinicians. Can you tell us a little bit about that?
So specifically, I was referring to residents. So we are in discussions now. When's the right time to introduce an ambient listening tool or any kind of AI tool for what it's worth? And I thought about it and reflected on this a little bit, and it makes me think about when computers became more prominent or in the smartphone, and how we were worried that that was going to interfere with the way we learn and our abilities to, I guess, just independently learn. And now everybody has a smartphone. Everybody has a way to do it. So we're in those discussions. If my personal views or professional views are, it's a tool in the tool belt. We can use it to benefit our clinical teams across the board. We need little guidelines, a little structure around it, but we should take advantage of what's available to us and just ease into it, but not go so slow. If you went any slower, you'd go backwards.
Any other questions? Oh, over there.
More of a comment. I'm Charlie Frazier. I'm the CMIO at Riverside Health. Thank you for all the success you've had with ambient AI. We use a bridge. We've seen some of the same sort of stats that you guys were publishing, but several of you talked about the cost of that. Some even talked about maybe some resistance of spending the money for that. One of the things, though, that we've seen is because it more accurately captures the breadth of the clinical discussion, a lot of times that will shift an E&M code to the next level. So we looked at almost 500,000 encounters, 167 providers across a bunch of different specialties from February of 2024 to June of this year. And on average, the amount that we got paid on average across those specialties is $3.44. If you look at that for 500,000 encounters, it's pretty easy to do the math. And for what we're paying, it's about a 3-to-1 investment. So all of the stuff about the provider experience that you guys were talking about, that's absolutely real. My favorite quote was, I got an email 2 weeks ago from a female colleague. He says, I used a bridge for the first time today. If you were here and it wasn't an HR violation, I'd kiss you right on the mouth. But there's financial benefit to this as well.
Thank you for sharing that. I think we had a question over.
Hi, I'm Roland DePret. I'm a graduate student in data science. And for the ambient notes folks, and obviously that's a hot topic, an interesting one. Are there plans to roll this out across all the interactions with the patients, or is it just focused on the attending physicians?
Are you asking about other disciplines like nursing and therapists, or are you asking
Yes,
about
yes.
different care settings? Okay.
Yes, especially like an inpatient, a lot of people interacting with the patient. What's the ultimate goal for those notes?
Yeah, I'm happy to start and then we can keep going. So I shouldn't have clarified because the answer is yes.
Mm.
Just yes, we are. This shows so much promise, and everyone who described it, they're all looking and going, I want that. I want it too. We don't have to beg them to sign up for the pilot. So we're actually looking at doing a nursing ambient next year. So working on what does that even look like and how would we do it for inpatient nursing setting? And then also for, especially around discharge summaries, that seems to have some really, or for the discharge process, that seems to have some real potential. So yes, looking at all of those, I mean, if I were going to be a betting person 10 years from now, they would think, oh, bless their hearts, they were asking if it's going to be everywhere. And yeah, it's going to be everywhere. And even perhaps in other non-clinical settings because the technology is there. So check in, that sort of thing. That's our plan.
We are definitely planning to roll out to our inpatient providers, APPs, PAs, NPs. We're looking at the nursing solution that's available that utilizes our mobile applications for the nursing. But I'll go back to our ambulatory setting where most documentation is through notes. And so there's opportunities that we're looking at with our physical therapist, our case managers, our social workers, and our nursing staff. So we are very much interested in partnering with anyone who wants to get started with our ambient listening tool.
Yeah, and I would echo that, and even into areas where we really didn't, you can't envision it right now because the technology is still evolving. Speech language pathology, other scenarios where you think, wow, it would be pretty difficult to, well, it's already happening. So yeah, it's going to happen.
That question over there.
Hi, my name's Kim Hardesty. I work for Elevance Health. I'm not coming to you with a question, but I'm coming to you from a patient saying thank you to all of you all. I'm going to tell you about my experience as a patient at Mary Washington and my provider. This is the first time I did not have my provider apologize for technology taking away. She was so excited about. First, she came in and said, introduce the technology and asked. And I said, sure, knowing she knew I was in healthcare technology. But I actually was able to have a conversation with her. She wasn't at the keyboard. And it was just great. So thank you guys for looking at these opportunities because it really does make a difference to the patient. So thank you.
Thank you. Any other questions before we switch to the next group? Oh, over here.
You can get it. You can get it. I'm just curious. Several of the organizations picked a project that was already in flight, and I wondered if there was a sense in which doing this in the framework of the Laura Breen well ops changed the sort of texture, feel, color, fuzziness, or whatever of the project in a meaningful way, or whether you just, I don't mean to be rude, but or whether you just sort of slotted this into that structure. Did it really change the project in any meaningful way or not, being a part of this overall program?
Were any of you those, or was it?
I'll just say that I think it did because the way we engaged with our clinicians across the organization changed. The way we had sort of a leadership focus on sort of how things were going and the community that was created around it. I think those all added sort of a flavor to this project that made it stand apart from some of the other things that we do just on a regular everyday basis. We do upgrades all the time. We bring in new technology all the time, but we're really taking the time to engage with our clinicians and our end users and ask them, how's it going? And actually looking at the data doesn't take a whole lot extra time to do that, but I think the impact is significant. And as a result, we now have clinicians who are interacting with patients and their peers who are saying good things about informatics instead of throwing us under the bus for how cumbersome something is. I mean, so this it really has changed the dynamic. We now have more super users that are sort of popping up in the organization where maybe people are feeling like they weren't being heard before, and that community, that conversation, I think helps a lot.
I think we had different people participate than probably would have if we had just done it without this program. So we really thought about bringing in a variety of disciplines and having them participate. And then I agree with the way that we communicate the results. It feels very focused on the outcomes and the adoption and less about, hey, we plugged something in, we got it going. It was much more about what happens after, like you were talking, Tracey, about the expansion and going from 10 people to 1,000. It was much more focused on the adoption side of it, which is a really good story. Sometimes, you ever gone through an EHR implementation? It's not always the best story for the next year. It kind of feels difficult. Nobody's happy about pretty much anything. So this felt like a totally different conversation where a lot more voices were involved. It felt very good to have that framing.
And I'll just add that I think it helped the interconnection between the different things that we're doing to try to promote healthcare worker well-being, as opposed to this is a EHR project that we're going to do.
Thank you all for that. Oh, one more question, then we'll switch.
So on the topic of wellness, how do you prevent this extra time that the providers now have? How do you prevent that from just creeping up and then that eventually just getting filled by appointment or more work?
Isn't the whole point to fill it with I'm kidding, right?
I was about to punch you.
It's actually been really interesting in our dialogue with the clinicians that you got to be careful about how you're talking about this, because it does very much feel like, oh, you're going to give me an hour back in my day and all of a sudden I'm going to have to do more. So we've been careful around how we evaluate that. So far, we've been seeing that the providers each individually are adjusting their way of working. They're still learning how to incorporate this. And I don't know that we've had anyone go, hey, sign me up, I want to hit more or whatever. I think we may get to some underperformers. We talked a lot about benchmarking and, are you in the what quartile, et cetera. We may get there, but it's not part of our initial rollout is actually hitting that metric. We've been very cautious against saying time equals more appointments, because that feels terrible and it feels contrary to what we were trying to do. And some of this is just faith. Time equals better. And I can't exactly say how that is, but it feels a lot better. Would you guys agree?
Well, Leigh, didn't you all see some patient experience scores and ratings go up for the first time that had been stagnant in this project? So the time is being spent with the current patients and improving those outcomes.
Yeah, it's really comprehensive. The impacts are on the patients, it's on the providers, it's on the care teams. I mean, we have a GME program that we're thinking about, just as Tracey was thinking about how do we leverage it. It feels it feels like a big change. We don't often get that anymore, right? We went from paper to EHRs 20 years ago, and to have things that are fundamentally changing the workday, it's been a while since we had something this momentous. So I think it's going to take us a little time to figure it out, but yeah.
Okay, we're going to switch to the next three, and then can we get this question with the next group? Yep. I'm going to ask a question first, and then we'll go to no worries.
Right?
Yes. Great. Well, so before we take more questions from the audience, what I would love to hear from the three of you, we talked about many different projects that were, investing in technology or just looking through a different lens of projects that you're working on right now. But as we know, our healthcare system and this topic of improving the experience for our health workforce and our patients is complex and it's a lot and it can feel overwhelming to try to change the whole healthcare system. But what are the things that your leadership can do to help you sustain and scale what you've started and where you hope to go in it with your own workforce? And whoever wants to go ahead.
Yeah, so we're very lucky at Inova to have a robust informatics team. And I think having leadership that supports having the clinicians embedded in the going live of these kinds of tasks and helping to prioritize which projects we're going to actually implement and on what timeline is vital because we feel the need and we experience it ourselves and we're able to kind of guide what is going to have the best return on investment as far as burden reduction goes. And I also think having, educational opportunities like we have a clinical informatics fellowship and we have one participant from that here. Just having that ability to foster the next generation and do that through a structured program at your institution and help get them in on the data and the project and participating in the well ops and actually writing out what this project is meant to be and what the goals are and learning that process together sponsored by our institution is vital. And now, we'll be able to take this exact procedure and then replicate it over and over again. So having robust informatics and also we didn't have an analytics resource for our project. So we had to do that all ourselves. And so having analytics, data integrity and being able to kind of get at least a self-service kind of slicer dicer or whatever other tool you would like to use to be able to analyze your smaller projects yourself without an analytics resource is also a hugely valuable item.
You got thought.
Yeah, I was going to echo that. And, embracing informatics is, we heard earlier, is not always really understood and what that difference is from IT or clinical applications analysts. So understanding around that and the value of it is important. But I would also say saving space for our clinicians to get involved from their side. To join a clinical informatics council, to be a super user for a new technology, to get the education they need to interact in the system the right way. I oversee IT education as well. And we have folks who come through at onboarding to learn how to use our EMR. And, you wonder if they've ever learned to use a computer. And so we don't think about it today, but there is a range of experience out there. And giving those clinicians the space to be there, not only selfishly does it build a pipeline for us to build our teams, but selfishly it adds depth to our clinicians so that they have the resources and the knowledge to ask the questions for themselves. And identify that I don't just want this shiny cool thing I saw at a conference. I want to understand the process that's broken, because putting a new shiny widget on top of a broken process, that doesn't get us anywhere. And people don't always see that. So that awareness about that and about how to work with their data, that for me is the leadership, is to start at the ground and really build those skills.
I'm going to take a slightly different approach, wake everyone up here. How many people have hundreds of projects in your IT pipeline right now? How many of you feel like they are effectively prioritized? Right? What is prioritization, right? So I challenge you all. If everything is important, nothing is important, right? So you need to use data, if at all possible, to identify what is important. The second thing, the big mistake that I see people make is not defining the problem. And that's one thing we do well in informatics, I feel, is we will sit back and say, what is the problem you are actually trying to solve, especially clinically, right? And so that's where kind of the magic happens, because, administration may want something and we come in and are like, well, consider this. Have you considered this instead? Have you considered the role of the end user, whether they're a nurse, a physical therapist, a physician, right? Who is going to be benefiting from this change? Where does the patient fit into this? So stopping to ask those questions ahead of time. I think a lot of things can be solved as well if you have governance that supports you on these prioritized items. And also when you have focus, you're able to bring in and explain the why a little bit better to your clinical leadership. So, for example, when I say, hey, we're going to get rid of the alert fatigue, and we got rid of 3.4 million BPAs firing over a year and a half. There was joy, there was support over it, but we talked to people, we made it a priority, and we went after it. Finally, I'll say having organizational leadership, clinical leadership at the table when you're implementing these solutions. Has anyone ever tried to implement Scrum methodology development? How did that go for y'all? Just I see, and usually the issue is, you have a Scrum master, but you're also supposed to have the product owner at the table, right? Supposed to have someone at the table on a regular basis to give you, cyclical feedback. You can have these rapid iterations, and that doesn't always happen. So making sure that your clinical leadership and your operational leadership is involved at all points can help for successful clinical implementations of whatever IT projects you're working on.
Feel like I'm on the Family Feud and I want to go, good answer.
Well, we'll go back to some more audience questions and start with where we left off.
Perfect. Thank you. Paul Mullen. I'm a pediatric ER from CHKD down in Norfolk, Virginia, and huge AI fan, big user. I sort of have the opposite question. The question that came in over there is, won't all this AI lead to more work for the clinicians? And the opposite question there would be, and as informatics experts, I'm curious on your insights on this, is with all the ambient AI listening, and this is myself as a clinician and my wife as a psychologist, is there some concern that with training all the data of these clinician-patient conversations, will we be sort of fostering maybe less work because, replacement by agents and sort of, this goes from ambient AI being clinician well-being to no longer being a clinician type vibe. And, just obviously not this year, next year, short term, huge gains, but what do you all think 10, 15, 20 years? Because to your point, Richard, I think it's all about the end user, right? With the patient. And, I think we've all had the experience where you're talking to a chat bot, you're online and you're like, I want human. You keep saying human operator, and you're like, you're trying to use whatever you can to, get around the system. But I think we're going to see a little bit of race to the bottom as it gets cheaper and cheaper to give more, AI agent care. So I'm just curious from the experts up here who maybe stay up at night thinking about some of these things.
I'll come into this first. So I want to go back to one of the previous questions I wanted to hop in on, and that was, should we give ambient technology to learners, right? I'm a firm believer, because I'm an educator, I was core faculty for years. You have to be able to write a good note first before you can recognize one, right? Can we all agree on that? You have to be able to write code before you can see if your AI agent is outputting good code to some degree, right? Obviously there's some human error element. Where I find these LLMs in particular that we're using, so, I think the big ones right now, I've got UpToDate asking me to evaluate their tool. There's open evidence a lot of people use. I've tortured my own folks with Truxgpt, some custom GPT that I use. They're just augmented intelligence, right? Right now, it is not to the point where I would feel comfortable. I don't have the confidence yet to be able to say it's going to replace us as clinicians. The other thing I don't think it can replace, I don't think our technology can ever exceed our humanity. There's power in the human touch. When I cry with one of my patients and I give them a hug and say, hey, I got your back, it's going to be okay. Machine can't do that, right? When I look at a differential diagnosis, it's going to help bring some of those things back from medical school that I may have forgotten. But that medicine knowledge is still there. It's still embedded, and it can bring it to the forefront for us. Now, 20 years down the road, I don't have the magic ball to be able to predict that. But I am excited for the first time as a geek who became a physician. I'm excited about the prospect of it helping us out. Maybe one day we'll have tricorders and instant medicine. I forget what they call those from Star Trek, but yeah, it is a concern. We need to, and I'm giving a talk on the ethics of AI in medicine in a few weeks. But we got to look at the the data models that we train, right? Make sure there is not implicit bias in those. We have to look at, you know, patient outcomes with LLMs, right? You know, and we started down that path when we started looking at like radiology applications, like looking at Hounsfield units and machine learning to make better diagnoses on, you know, radiological films and such. But you're right. It's something I don't have the answer to. I don't think we will have the answer to until we get further, you know, further down and Moore's law takes effect again and we have much, much more compute. Thoughts?
So we have about 1,000 users live in ambulatory on an ambient solution as well, and I can promise you that our patient satisfaction isn't going up because my note is better. It's going up because I'm able to sit there and talk to them and listen to them and actually spend the time that I need to spend with them as their clinician. And then my note just kind of writes itself, right? And so I can't imagine an AI like making that better for my patient. So I think it's more of a useful tool. Maybe it will extend us, maybe it will make us more efficient, and maybe it will, give us the time to go home and watch Jeopardy and that kind of stuff and actually be a better, happier human and still be a great clinician and actually connect with our people. That's my take.
Yeah, coming from the nursing perspective, what I look forward to as more and more AI is coming for nursing is that time to actually lay hands, because AI is not going to turn and tuck my patient. They're not going to help me change that wound dressing, at least today. I'm making no claims about 20 years from now. And, there is still, to your point, the humanity of healthcare, the hands of healthcare. And I hope that AI continues to make us better at what we need to do so that we can do a better job with everything else.
Any other questions from the audience?
Hi, I'm Rachel Pryor with VHHA, and I'm a nurse by background. So I spent the beginning of my career in the ICU and then moved into an analyst in quality and infection prevention. So speaking very directly to these onerous alerts in the EMR that as a bedside nurse drove me insane. But then working in quality and particularly in infection prevention, everyone's favorite department in the hospital, we enacted all sorts of alerts, or basically hard stops, soft stops, to prevent orders for testing that we didn't believe was necessary without going through the correct process. So we improved our numbers dramatically for some of our HAI rates because testing wasn't ordered that shouldn't have been ordered. But we got some free text responses to some of the soft stops, which were quite interesting, to say the least. And also in quality, force function is shown an evidence-based way to improve outcomes, and education is a least best way to improve outcomes. So did you work with your quality teams on this fine line of balancing the burnout? And if so, could you speak to that, or is that something you're planning to do a little more?
So the alerts that we attacked in this initial phase really didn't have a hard quality eye, because I agree with you. There is a line between force functioning for safety. The alerts need to exist for a reason, hard and soft. But making sure, to your point, telling me that I may be ordering a test that's clinically not indicated, that's going to cause my hospital to take on an HAI that is then going to affect our reimbursement. That's a valid thing, assuming that it's actionable, assuming that it is in the right place in my workflow to make the difference. Alerts can work. It's just having that critical eye to figure out if we're doing it the way we should be, and taking that feedback when we also have a little spot in ours with an alert pops up. There's a box they can click and they can leave feedback, which is, feedback is a gift usually. But yeah, I'm not anti-alert by any stretch. And certainly that's where this has become conversation. So I made the reference about a patient safety event happens and we should put in an alert, but it's having that conversation to say, is that the best way? Is there something else apart? Is there a process problem that the alert's not even going to fix because someone's going to blow right past it? So just the questioning attitude.
Yeah, I fully agree with that, because if you have so many alerts, then they decrease the function of the ones that you really need, right? And make you just become completely blind to the really important one. So if you cut down on the overall volume, then the ones that are important, you're more likely to get action on.
So I've dealt with our quality department direct on multiple things. We were getting rid of 3.4 million alerts that were not needed. One of them was on C. diff. Our C. diff rates were climbing up, and we found out a lot of patients were having C. diff tests ordered on them when they were on laxatives, right? And I found, I come from a sales background, and so I'm a big fan of having a disruptor to get someone's attention. We added so the health of the BPA was horrible. It was less than 1%. So what I did was I built a BPA that looked at, if they're on a laxative, if someone ordered the C. diff test, it would pop up, which is what our quality department asked. But then I did one other thing. I added a laughing poop emoji picture. Health went through the roof, 22%, right? And people can say, oh, was that professional or not? Did it have the outcome we needed, right? And we could all use a little levity in our workday, right? Another thing is we don't have the conversations we used to. We want to use technology because we don't want to talk to people anymore. And so I sat on our lab stewardship committee, and we had a similar issue where they wanted to build a BPA for vitamin D. And when I looked at the data, there was one psychiatrist ordering the wrong form of vitamin D who accounted for 92% of the issues. So I just picked up the phone and called them and said, hey, did you know you were ordering the wrong form of vitamin D? Like, order this test instead. Oh, I didn't know that. Thank you. Problem solved. So anytime there's if you can find like 2 or 3 outliers in your data, pick up the phone and have a human conversation with them. And a lot of times that'll fix the issue.
Other questions? Oh, over there.
So specifically still on the topic of alerts, I know that it was mentioned about the alerts with nursing. We're seeing a new generation, especially at our organization, where the new nurses are relying very heavily on the alerts. So how do you combat that culture where you have nurses that are relying heavily on it right out of school, but then starting to ignore it once they've been in the organization for a while?
So you're getting to the point that nurses coming out of school are very task oriented. And I'd argue that that's not a new phenomenon. Um, with the way our system is set up, we have some different avenues where we can help that. We have a task list that we use. We have the alerts. We have a set of passive alerts. So we try to be thoughtful. We don't want to task the nurses to death to say, here, do your assessment. Here, do your vitals. Here, but we try to pull the ones that might be hard to remember or on a set time. We try to be thoughtful about that because of that, because we'll have some people say our task lists are terrible. And sometimes they are, but sometimes it's necessary. So it's walking the line, and it goes back to my talking about having frontline clinicians that can have the conversation too. And we'll bring new tasks to our clinical informatics council to say, what do you think? And get that feedback, say, oh gosh, please don't task me every 15 minutes to do my restraint check. I know if that patient is in a violent restraint and needs a 15-minute check, I got it. Don't hit all the boxes. And so getting that feedback and talking through, and then the education, working with the newer staff to help them see that. But it's tough when you task some things or alert some things, but not others. It's challenging. Relatedly, in our talk about ambient scribing and students and things, I was thinking about when I was in nursing school, EMRs were really, they were around, but they were becoming more popular. And so we all still learned a paper chart in school, and everybody was annoyed and why am I learning this? I'm going to go work at the hospital over there that's got the new system. But now that is so valuable in AI because a lot of the nursing tools are kind of dictation based and talking through. And so, where I learned, oh, so you're denying that you're not nauseous, you're not vomiting, you're not, and that write out that I used to have to do that my classmates hated so much. Like now what's old is new again with AI. And that's a feedback I'm hearing about the nursing AI is, oh, I have to remember to say all of that stuff and I can't just follow my click boxes and go down. And again, it's that new clinician coming in and the world changing. So.
I would love to have alerts. So I look at alerts as clinical decision support, right? There should be something educational to the end user there to correct their behavior or to teach them something. but how cool would it be if we had some type of augmented intelligence that could have a BPA score or something like that? So as the end user learned, it would give them a little bit of grace and maybe not fire as often, right? Because sometimes there's use cases where alerts are firing to specialists who may need to order a certain medication. Like if for example, if one of our infectious disease specialists wants to order colistim for somebody, I'm not going to tell them no, right? They probably have a really good reason for wanting to put that patient's renal function at risk, right? On the same token, I probably wouldn't want someone like a resident writing that medicine. I'd want alerts all over the place and go in the pharmacy and everything else. So there's probably some happy medium there, but I look at alerts as when we create them, they should be like a teaching tool.
Any other questions? Okay. Well, thank you all for your time. And I think the summary point I want to make is, as you all continue the conference and the conversation of human-centered design, is our caregivers, our clinicians are humans too. So every project that you all are working on, just ask the question, how will this impact the clinician or the health worker in addition to the patient? And we can make their lives so much easier to just reduce the stressors that they have during the day so that they can focus on those amazing patient experiences like one that was shared back there before. So thank you.
Thank you to the panelists. This was a great presentation. Obviously, you got to see all the good work that was done. Just a reminder, they put some of these in the middle of the table. They've impacted over 2 million licensed workers. So it's a monumental effort. Virginia is the first to do all this. So they're going to spread out to other states. And it's a great cause. So thank you, everybody.
Thank you.